Hi, everyone. We'll get started in just a minute, just letting people into the Zoom webinar room. Thank you for joining. Hey, everyone. If you're just joining us, we'll start in just a minute, so please stand by. Thank you. All right, so we're going to get started. It's already 2:01, so thank you all for joining. Good morning to you all if you're on the West Coast or in Hawaii, and good afternoon to the rest of you if you're, Central or East Coast time. I'm Albert Eisen Jr. I am the Associate Director of Training and Technical Assistance at AAPCHO, and I'm joined by three of my colleagues from the Health Outreach Partners, MHP Salud, and the National Healthcare for the Homeless Council. All four of us organizations are HRSA-funded National Training and Technical Assistance Partners, and so you'll get introduced to my colleagues very shortly. So the agenda today is an hour-and-a-half session. We'll have plenty of time for Q&A and discussion towards the end, but we encourage you all to drop your questions into the Q&A pod, which I'll explain very shortly if you're new to Zoom. But we'll have content from four of our organizations, all related to the importance of the enabling services workforce, especially in the context of COVID-19 and the need to do social needs screening for your patients at the health centers that you're serving or working with. So this is just a quick agenda for the hour-and-a-half. Again, the purpose of this webinar is to explore strategies to screen special and vulnerable populations for social determinants of health and build effective practices to begin addressing the SDOH through enabling services. And given the COVID-19 pandemic that we're in, this training will highlight the critical importance for your enabling services providers to collect the social risk data amongst your health center patients. And we have our three learning objectives here by the end. We hope you all will be able to identify the enabling services workforce providers for your SDOH screening and documentation efforts, especially during COVID-19. Second is that you'll be able to demonstrate the overall value and impact of enabling services and how those enabling services can highlight key structural inequities. And lastly, we'll close out with ways for you to provide tools and resources for yourself and for your staff and colleagues on assessing the needs of special and vulnerable populations, for example, those experiencing homelessness. All right, so if you're new to Zoom, I just want to do some quick housekeeping here for the attendees. The first is the audio. If you click on the mute and unmute button on the left-hand corner, you'll see that button, which will allow you to use your microphone. Towards the end, we'll be able to let you all speak up if you want to through the raise hand and lower hand, but we'll kind of direct you towards that portion of the webinar because the first hour will mainly be presentation and didactic from the presentations today. So just be mindful of that. And in order to minimize background noise, us panelists will be unmuting and muting ourselves throughout the presentation. All right, so the next key area for Zoom webinars is your Q&A box. So during the presentations, we highly encourage you to ask all and many questions that come up in your head. You just simply click the Q&A button on your control panel and type your questions into the free text field. The moderators, myself and my colleagues here we'll be sending you typed responses, or we'll save those questions to answer live towards the end. And you all as attendees can also upvote or pretty much mark questions that you have that are already being asked in the Q&A pod. So I encourage you all to use the upvote button, which is here, like the thumbs up button. So that'll help us triage and prioritize which questions may be most relevant to all. All right, and then I want to point out the chat box because we'll be using this for some of the live polling that will happen throughout the presentations. So if you simply click the chat, you can communicate with us panelists and with other attendees anytime during the session. So do chat us if you have any troubleshooting issues, and we encourage you again to use the Q&A box for specific questions related to the content, and using the chat box more for the troubleshooting with the Zoom tech issues, or if you want the slides, again, that'll be available for download using the link in your chat box, and we'll populate that every so often since some of you might be jumping on now. All right, the last feature I want to highlight is the raise hand, lower hand. So this will come in handy during the Q&A portion and discussion question, where some of you who might want to speak up will ask that you kind of raise your hand and lower your hand. That way we can make note to unmute yourself, because right now you won't be able to do that. So stay tuned for that towards the last half hour of the session. And if you do need to leave us early, you simply click the leave meeting on the bottom right-hand corner, and that should allow you to safely and smoothly leave the Zoom webinar room. And that'll pop up a link to the SurveyMonkey, which will just ask for 2 to 3 minutes of your time to provide us your feedback. All right, so I mentioned that I'm joined by 3 colleagues here. My first one is Bellany Reese. She is a project manager at Health Outreach Partners. And then followed by Brett Poe, the research associate at the National Healthcare for the Homeless Council. And lastly, we'll have Esley Reyes, program director from MHP Salud. So you'll hear from all of us today. So I'm just going to kick it off with the first learning objective and talking about the enabling services workforce and the providers who might be screening for SDOH during the time of COVID or just during your regular operations. So just to get everyone on the same page, when we do talk about enabling services, we are talking about the non-clinical services that promote, support, and assist in delivery of healthcare and facilitate access to quality patient care. And some examples of these enabling services, as you see on your left-hand side, are transportation, interpretation or translation, case management, eligibility assistance, outreach, and others that you might be offering directly in your health center or care delivery setting. And so if you think about enabling services in the context of today, the current COVID-19 crisis has clearly demonstrated the value of the enabling services workforce, especially as health centers and healthcare providers continue to address some of the rising social determinant of health needs of patients who might be unemployed, uninsured, stressed, food insecure, homeless, and just overall at risk for different chronic or social conditions. And we know that enabling services, or social interventions, as we like to call it nowadays, are important because they are foundational to ensuring access to preventative care, which can in turn improve health outcomes and then lower the healthcare costs or total cost of care for your patients with these high-risk conditions, which may include the unmet SDOH needs. So to that end, I think many of you and your colleagues in the health center or care delivery system settings can tell a great story of how enabling services positively impact your patients' health outcomes and how they can address the different social determinants of health that are rising and becoming more evident each and every day. And for those of you who've been able to tune into the recent presentations from HRSA's Bureau of Primary Healthcare, there has been recent Uniform Data System or UDS analyses that show tremendous growth in the health center workforce and across many different disciplines. This table here on your screen shows percentage change, for example, from calendar year 2017 to 2019. And you'll see that some of the biggest growth by discipline has occurred for the nurse practitioners, psychiatrists, mental health and substance use disorder providers, other professional services, and vision service providers. However, for the sake of today's presentation, we'll be focusing on enabling services providers, which have shown modest growth or 11% increase within the span of the last 3 years. And so for today, we're collecting good data through HRSA's Uniform Data System reporting requirements if you're a health center. And we currently have 8 enabling services categories under the HRSA UDS, and you'll see this on your screen here. And health centers are required to report the full-time equivalents or FTEs of these types of enabling services providers, along with some of their visits and the number of unduplicated patients that are served in the health center. In order to capture better data, though, on enabling services, some of us NTAPs, or the National Training and Technical Assistance Partners, have had conversations with HRSA, and they're really excited about taking a step further to really demonstrate the value and impact of the enabling services workforce, which my colleagues will talk about in the next sections. Just an example, the NTAPs like us are taking some of the kind of ES data collection initiatives and advocating for more standardized data points, especially as we see more uptake with social needs screening in the health center setting. And this table here is just another look at the trends over time for the enabling services workforce from 2015 to 2019. And you'll see that the biggest percentage change and growth over the last 5 years occurred for the case managers, transportation providers, and community health workers, all of whom have been important and critical when it comes to addressing and assessing the social determinants of health for health center patients. My colleague, Leslie from MHP Salud, will present after me and will talk further about the role of enabling services, especially for community health workers. So stay tuned for more good information coming our way. In the previous slide, I also mentioned the national initiatives on capturing better enabling services data. And one of those initiatives is work that AAPCHO, Health Outreach Partners, and National Healthcare for the Homeless has been doing for almost a decade to collect not 8, but 15 enabling services categories. And these categories were vetted by an advisory group of health centers, primary care associations, and even some health center control networks a few years ago in 2017. And we've been doing a lot of advocacy and kind of promotion of these different categories in order to fully reflect the different types and breadth of services that are being provided routinely by health centers. The data that comes in the enabling services data collection toolkit that AAPCHO developed back in the early 2000s has data on the volume and length of time for enabling services. So you would have kind of the counts and the length of visit for health education versus outreach versus case management. That way you can really advocate for more funding or for better reallocation of resources internally within the health center program. So just want to share that here. And this table here on your screen presents the juxtaposition of the old enabling services categories used in the early 2000s through the Enabling Services Accountability Project. And then the other categories in the middle column here are the ones updated in 2017 in partnership with, again, HOP and NHCHC. And this was, again, a steering committee of health centers who felt that these categories and refreshed categories were better distinguished to, again, present the array of services being provided by your workforce in the health centers. We know that this is not comprehensive nor exhaustive, so we encourage all of you to think about who your workforce people are and what services you're providing, and add those additional categories to your EHR templates. But we feel that these are kind of the minimum and basic categories to really capture impact and value. And just want to mention here also from a recent HRSA presentation that according to the 2019 Uniform Data Systems, about 70% of health centers have reported collecting data on individual patient social risk factors, which is great. And we hope to see that grow to 100% over the next year or two. And then there was word that 23% are in the planning stages to collect this. So we feel that hopefully these trainings and learning collaboratives that we'll be offering through the NTAPs will help boost that number up. So that way we have 100% uptake in social needs screening within the health center program. And according to the 2019 UDS as well, a majority of the health centers, 34.4% or 1 in 3 health centers reported using PREPARE, which stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And again, this was a social reach screening tool developed by NAC, AAPCHO, and Oregon Primary Care Association around 2013. And lastly, the other big tools out there like the CMS, Accountable Health Communities, was yet another social risk screening tool that is being used by health centers across the US. The following list here, I'll hyperlink it in the chat box shortly, but this is just a comprehensive list of the different social needs screening tools that have been implemented, especially for the adult populations that you are serving. And this is provided by the University of California, San Francisco's Siren network. So they have definitely done a comparison table for all the different social risk screening tools. And you'll see here, I'll point out that PREPARE shows up here, and its patient and population of focus are the health centers, which you all are our target audience for today's webinar. And I'll point out that there is the UDS question that you all are required at the health centers to report on now annually. And one of those questions includes which standardized screeners you're using for social risk factors. And I'm actually going to test this out with you all here today through a polling question just to see what you all are using now. So give me a minute here. All right, so you should see a poll launch now. So please take a minute to note which standardized screener for social risk factors, if any, do you use? And you can select all that apply. We acknowledge that you may be using multiple social risk screening tools in your health center or across your health center sites. And if you're using a tool that's not on here, please use the chat box to let that be known. Great, so I'm gonna wait till we get to the 50% mark, but we have 88 out of 239 voted, and we're seeing a lot of PREPARE users, followed by WeCare and the recommended social and behavioral domains in your EHRs. This is great. So I'll give it another 10 seconds for y'all to put in your vote. Which standardized screening tools are you using? And if you don't use one, you can just note I or the last. Yeah, we have about, okay, I'm gonna end the poll now and share the results with you all. We've reached about 50%. Okay, so yeah, again, about 45% majority are using PREPARE. We have 24% of you in the virtual room today who are not using a standardized screener. So we hope that you can use the Siren comparison table to kind of choose the one that's best for your setting. We have, again, recommended tools in your EHR. Some of you, 13%, are using the CMS tool. And yeah, it's sprinkled all over the place, which is not surprising. So thanks for, let's see, I see Alyssa said we use California state mandated Staying Healthy Pearls tool. Great, yeah, we acknowledge that there are national social risk screening tools, but there might be some drivers within your state or locality for social needs screening. So, you know, hopefully there's alignment across the different data sources and data fields. All right, thanks for participating in that poll. I have a few more slides left before I pass it on to Esley, but I just want to note that, yeah, health centers have focused on the social determinants of health for decades and since their inception. But what has changed is that health centers are now collecting standardized data on the SDOH and enabling services, given the UDS requirements and kind of the mandates from our reporting structures through the Bureau of Primary Healthcare Program. And the push for the standardized data, again, largely comes from also the transition from value-based care from a volume-based to a value-based healthcare system where, again, organizations like health centers are going to be responsible and are responsible for improving health outcomes that are both related to clinical but non-clinical. So understanding the full scope of your patient populations and addressing their needs is going to be important. And with standardized data, health centers can do the following, especially with COVID-19 affecting a lot of our operations and care delivery. For example, at the individual and community level, SDOH data can help you all identify and address top social needs of highly vulnerable groups at high risk for COVID-19, including people experiencing homelessness, food insecure individuals, the unemployed, and you can use those data points to really target and outreach to groups in collaboration with your community-based organizations or cross-sector partners. That can include food banks, homeless shelters, employment assisters, et cetera. At the population level, for example, the SDOH data you collect can identify patients and populations who are at higher risk of simultaneous complications, hospitalizations, or deaths due to COVID-19. And you can do that through some great risk stratification in your EHR or population health vendor tools. So, with all that data coming through on your patients, you can really see who are most at risk, and social risk identification is becoming more and more common across the health center and healthcare systems. And then lastly, from a kind of a systems and policy level, the social determinants of health data can really help elucidate the trends regarding, for example, how COVID-19 and the virus is disproportionately affecting certain groups with certain social risk barriers. And we've seen in the news, for example, the Black, Latino, Native American, or the BIPOC populations are really struggling from the higher rates of COVID-19 cases and deaths. And so we want to use that data to really inform policy, resource allocation, and health equity conversations and programs. Alrighty, and this fact sheet here provided to you by the Prepared team really talks more in depth about the impact of COVID-19 and the social determinants of health. So we'll be having this provided in the link after the webinar, and you can download it when you have the slides. You just click on this link here. It goes really in detail on the different domains or questions in Prepare and its association with COVID-19. Just lastly, I know Esley's going to go into this a little bit, but there's a lot of impact of COVID-19 on the enabling services workforce. Some of the big areas that we're seeing impact are just the infrastructure of the health center and the workforce within the health center. We're seeing the impact on kind of the delivery system, for example, outreach and enrollment, case management, et cetera. We're really seeing more and more need for it, but also on the flip side, there are those furloughs or closing of sites during COVID that have really kind of jeopardized the balance in the workforce versus the delivery systems. In terms of workforce and policy, there's a lot of, again, technical knowledge and challenges around kind of what resources to provide to your patients during this time, including the social determinants of health. I think we're still learning through some of the data coming in at the health center or through HRSA, what it is we need to do in order to address some of the health disparities and health inequities affecting our patient populations. In terms of demonstrating value, again, we want to use some of this preliminary data or standardized data to really do some advocacy for sustainability and expansion of enabling services workforce so that we can continue to address the SDOH needs of our patients. And this is going to be talked about through Brett's section, again, just the populations of focus and the special and vulnerable populations you all may serve. will really impact kind of the workflow and how to really meet the needs of those highest risks for COVID-19 and social risks. So I won't belabor you. You can read this on your own time. In terms of what workflows to use for SDOH screening, we often like to introduce the 5 rights framework. This helps all implementers kind of walk through key questions related to the who, what, when, where, and why. And this is included in the Prepare Toolkit, which I will again hyperlink later on and after the webinar. There's some key questions again to consider about, how will you administer the social needs screening tool? Who will collect the social needs screening data? Will it be before, after the visit, during the visit, and kind of where? For example, is it going to be on paper? Is it on EHR, or is it on a tablet? There's so many different workflows out there. It's going to be really ultimately customized to your settings, including kind of the capacity and workforce you have at your health center. And this is a sample table of workflow models, which I will not get into. I'm only going to highlight one here, which is the non-clinical staff or enabling services. And here's the example here. Using your ES staff for screening after a visit is useful because you often get to, again, employ your enabling services staff to connect with your patients and really understand their needs and build that trust. And they can also connect your patients to community resources within the health center setting or outside of the health center setting. Again, there's some advantages and disadvantages and trade-offs here that you can read on your own, but we encourage you all to leverage your enabling services workforce at the end of the day, given that clinicians might be burned out or overwhelmed with other visit needs of your patient. And this is just one example I want to highlight is Siouxland Community Health Center in Iowa, how they've been using SDOH and through Prepare, addressing food insecurity for diabetic patients. And there's an article that was published in their local Sioux City Journal that was amazing and highlights their great work on a local level. So thanks to Dr. Feldmill there at Siouxland. Some resources. And I'm going to now pass it on to Esley from MHP Salud.
Thank you. Thank you so much, Albert. Hello, everyone. My name is Esley Reyes. I am a program director at MHP Salud. And if you're not familiar with who we are, real quick, we promote the community health worker profession through training and technical assistance, and we provide these services to many health centers and other organizations nationwide who wish to start or strengthen their CHW programs. And this next section will focus on different strategies to demonstrate the impact and value of enabling services, keeping in mind that community health workers or CHWs are part of our enabling services workforce. So we can start. Let's move forward to the next slide. Thank you so much. So as we have heard, enabling services are an integral part of care teams and health institutions. So let's look deeper into understanding the different types or levels of impact, right? So let's start with health outcome. It is good to know that enabling services work has produced many positive outcomes. Actually, there is ample literature out there and studies that support the benefit of enabling services work. And to give you some examples on the outcomes they have produced among special and vulnerable populations, we can think about the huge success that CHWs have accomplished with patients that are struggling with chronic diseases such as diabetes or hypertension and comorbidities. And they can do this because their ability of getting to know the patient, right? They're from the community most of the time. They have this one-to-one knowledge, and they're able to identify the barriers each individual or patient are experiencing in accessing care, and among many populations, including homeless, immigrants, etc. But let's move forward to the impact on service delivery and quality of care. We know health centers provide primary and preventive care for diverse populations, right? So we also know that the value of enabling services work does not only improve the individual practices, but it also improves the way the care team works together and the way a health center serves the community, right? And their impact to all these special populations that may face a wide array of cultural, economic, linguistic barriers, which are SDOH, right? The topic of our webinar, and how these may inhibit patients from achieving good health, right? So many health providers, health centers, and communities have found that enabling services such as community health workers can help make healthcare systems more responsive by communicating information from the community back to healthcare professionals and vice versa, right? So we often say that there's that bridge of communications and link to health and social services. And they do this by integrating case management. They increase personal follow-ups, home visits, outreach, and enrollment, etc. So let's move forward to the next slide, please. There is a fourth impact. So I know in the past slide, I just quickly went through 3, but this fourth impact is very important, which is the topic that I will be focusing on most of the my section, and this is return on investment, or ROI. And some of you may be already familiar with it, but essentially it is a method to further evaluate and understand the value of enabling service staff by looking at our economic impact of ROI. So in a simple definition, ROI calculates the total value of the benefit or profit resulting from a program, and this is divided by the total program or intervention cost. So let's look at it on simple terms. So let's move to the next slide, please. So ROI is basically the money your organization could be saving and how much money or resources are put in and what you get out of it. Next slide, please. And well, with ROI, or return on investments, there's a lot of benefits, right? When thinking about the great work of enabling services and the great addition of enabling service to our care teams and health centers, it is important to recognize some of the benefits. And one of them is that it's relatively easy to understand. It always happens when we want to influence decisions of decision makers, right? Talking with money. It estimates direct financial impact. It is very versatile, and also it can be individualized, right? So it can be used financial and non-financial components to show the value. It also supports sustainability by showing how funding the program creates its own savings. And finally, but not least, it is considered a common and basic estimate of profitability. And nowadays, many people are using it or at least aware of it, right? So let's move forward and try to understand a little bit more about ROI. Next slide, please. So ROI has 3 different types or levels that we could obtain thinking about an enabling services program, intervention, or initiative. And they are community level, institutional level, and individual level. So let's go over some examples for each so we can better understand these levels. So next slide, please. Let's start with the community level. So for the community level, we can look at how much or what is the benefit or return is the entire community receiving as a result of investment by the community, right? I try to put an example that was clear and easy for us to understand, but we can think about preventing or decreasing as a community, right? As a mass of people, preventing and decreasing the number of hospitalization because patients or community members are attaching to their care plans. And this could be a result of enabling services, maybe outreach workers, right? Understanding SDOH barriers and providing outreach, maybe case management, constant follow-up. So we have patients or community members that are more aware, right, of their health, and they're taking better care on themselves. How do we show this? Well, ROI will be perfect because we'll be able to say, hey, based on this intervention, this is the result, right? On decrease on hospitalizations. So next slide, please. So let's move forward with institutional level. So what return did the host clinic or health center receive based on enabling services inputs, right? Example, maybe we base on enabling services doing close monitoring of patients, close follow-up. COVID, right, has moved every organization into virtual platforms, into maybe telehealth, telemedicine. They're able to call them. So maybe that enabling services, we're able to show the value by saying, okay, so the work of enabling services has helped us to increase patient attendance to doctor's appointments, or decrease missed appointments, right, due to enabling services. And we know the results, right? There's also, that is linked also to an improving health outcomes as well. And next slide, please. Yeah. Individual level, perfect. So what savings did the individual receive based on inputs to their program? So thinking about a patient or an individual, right? So maybe we can see a decrease out-of-pocket costs. Maybe they are battling diabetes, right? And this could be due to enabling services staff providing education, follow-up, case management, so they're able to take better care of their health, stabilize their A1C, therefore less medication is needed, less money out of their pocket, right? And these are just some examples where we can see that ROI can really open the eyes for many people, decision makers, for providers, right? We are, a lot of the times, one of the struggles that we see among care teams is acceptance, right? Or buy-in on even of enabling services work and staff. So we can move forward. Thank you. As we see, enabling services interventions could produce 3 different types of, or levels of ROI, right? We talk about community, organization, and individual. And having these 3 levels is important as it allows us to better show the impact and value of enabling services, their work, their interventions on a larger scope. And it's very important for us to, when we are, maybe some of us are already having in mind an intervention that our enabling services are currently doing in our clinics. And it's important for us to keep in mind these 3 levels all along. And we'll learn a little bit more about this as we move forward to the next slide. So to see how these come into play, I brought some real examples from health centers, and we can start with one. So I'll read it really quick. A patient who receives services from a community health worker and learns how to better care for their health, which then results in lower medical costs for them for the rest of their life, is a foregone cost or unrealized cost, money not spent that would have been needed otherwise, right? So we have an explanation, but these maybe will be, this concept will go into an ROI equation, ideally, to make it more representative of the outcomes. And if we move to the next slide, we can see how ROI equations or excerpts look like. So I'll just read 1 or 2. So we can see the first one. So all of these are ROIs based on community health worker interventions. So we have Denver Health. So they saw a return on investment of $2.28 in savings for each dollar spent due to decrease in urgent care and uncompensated costs. So the annual savings were over $95,000, right? All of these because of community health worker intervention. We can see the next one, Arkansas Community Connector Program. They track Medicaid spending of 900 patients, and they saw a 3-year saving of over 2.6 million, right? Or 2.92 savings for each dollar spent. And these are just some examples on a way that we can take that step forward to showcase the value of our enabling services workforce. So next slide. So I know I probably flew through ROI, and we have time limitations on this webinar, but in just a few minutes, we'll learn about kind of the concept of ROI, the importance, the usefulness, and if you or your organization is interested in learning more about it, maybe giving it a try, MHP Salud has developed this ROI educational tool that you see on your screen, which is a guide for conducting a return on investment analysis of your community health worker program. However, it could be useful for any other types of staff or job titles, and it includes different sections such as how do you how do you find, or what do you need from your organization to build your own ROI team, how to gather your numbers, your data, your financial information. It also provides step-by-step guidance on the ROI calculation. Also, it focuses on how to report it, right? Reported methodology. So we can move to the next slide. I want to show you just some cool things from our toolkit. Is that it starts with a self-assessment that helps you understand where you're at, right? It assesses if you're ready to start calculating ROI. It maybe helps you identify what kind of data we need to gather to start ROI, depending on what value you are trying to showcase. And if you're already doing it, it can also help you to strengthen your ROI calculations, right? What type, maybe broaden your categories that you're doing your ROI calculations. And through it all, you will see these three icons, and where it guides you to obtain the information you need, right? The how to, then it moves you through different health center examples. So you see how they're applied, and then it lets you try it. The goal of the toolkit is that you're able to produce an ROI. Well, you're at stage 1 or maybe in the middle, you already have data, but you just want to know how to. This is a great tool that you can use. And our toolkit is found on MHP Salud's website. And after my section, I will be happy to share the link with you in the chat box, but you also have it as part of your slide deck that has been provided through our chat box. All right, so next slide. Thank you so much. All right, so thinking about the measurable value of enabling services in screening for SDOH and being able to fully equip and understand the struggles the patients or communities are facing, I just wanted to quickly drop these two slides to showcase some of the great work that our enabling service staff are able to do as a response to our current pandemic or COVID-19. And real quick, I would only like to highlight a couple. So we could see here that during COVID-19, I think we can all agree with being flooded with information, and sometimes this information may not be provided in a way that it could be understood by our patients or our community, right? Whether it's language, leadership level, etc. So this is where enabling services come in and provides education, right? And resources in a way that it's in their language and it's easy for them to understand. On that note, enabling services are also able to be that link, as I repeated earlier, right? And especially during these times that a lot of questions, right? A lot of fear comes up. So they're that link that is connecting our patients or our community to all the health and social services that are specifically more important during the times that we're living right now. So we can move to the next one, please. And one big one from this list is reaching our populations or patients where they're at. As we started our presentation, I mentioned that enabling services they know the community, they trusted by the patient population, right? And during this time, specifically important that our enabling services are still present to help, right? Present to do their outreach, present to have that connection with patients, because remember, they're the kind of like our eyes and feet out there, going outside from our health center. So during this time, we have seen that enabling services have adapted well to the virtual learning, right? To being able to be present for those people, individuals that are still in need, right? And we can see virtual services. As an organization, we've implemented some virtual outreach where we use phones, Zoom, WhatsApp, telehealth, telemedicine, etc. And well, all of these are just examples that help us understand that the work of enabling services is extremely valuable, right? Especially during COVID-19 times. So next slide. To close off my section, overall, we know that showcasing the value of enabling services is important, right? And understanding and participating in the ROI process helps and arms you with, and your organization with the knowledge you need to define your program. It also helps you to ensure sustainability of enabling services positions and continue overall strengthening these professions, right, as a way to better serve your patients, your communities. It is also important to understand that ROI, together with all the other qualitative information such as success stories, testimonials, and other type of data and information showcasing the great work they're doing right now, comes together to demonstrate the overarching value of enabling services. And something that I would like to add is that be that advocate for that buy-in, right? Periodically sharing the success of enabling services with health center leadership, providers, entire care teams allows them and gives them, promotes the value, respect, and credibility to their professions. And overall, it strengthens their workforce. So with that in mind and thinking about, we can move to the next slide, thinking about what are you currently doing within your health centers to promote or to showcase the value of enabling services, I wanted to open this poll question, and feel free to type your response into the chat box. And my question is, what strategies have you or your organization found helpful in demonstrating the value of enabling services staff? And feel free to type any of your, we have around less than a minute. Tracking cohorts for improvement, of course, right? As we talked about, always showcasing, we have direct programming, so we do a lot of pre and post for our groups, right? Especially if you have patients with a comorbidity, those are great and provide great data. Services highlighted by CMO at provider meetings, right? And I would like to just to close out, I'll continue typing and I'll be able to, but some of the answers that we've heard from health centers is that they're also able to highlight their success and patient experiences through health center digests or newsletters or mailings. I see Lindsay mentions that leadership team has sent them gift cards to show their thankfulness. Awesome. Right, they share the stories, right, with the leadership, with board. Those are all great answers. Awesome. I will continue reading over your responses, and we can talk more about it towards the end of our webinar. And before and no further ado, I would like to pass this on to Melanie. So take it on, Melanie.
Thank you so much, Esli. Hi, everyone. My name is Melanie Reese. I am a project manager with Health Outreach Partners. And before I jump into my portion of the presentation, I just want to give a bit of a disclaimer and let you know that what we'll be talking about over the next several minutes departs a little bit from the more concrete resource and tool-based processes that my colleagues Albert and Esli have shared with us thus far. It's really meant to complement those, though, by providing an even bigger picture perspective of social determinants of health and emphasizing the really important role and impact of enabling services data collection. And so I encourage you and even challenge you to keep in mind what we explore here as you reflect back on today's webinar and as you continue to address social determinants of health in whatever capacity you do going forward. Now, I want to start by taking a look at the idea of social determinants of health, what they are and how they're used when we talk about health equity. So as Albert mentioned a little bit earlier, the term social determinants of health, or SDOH, it's not new. It's been around for the last several decades, and it's been used more and more in the last few. But especially as healthcare providers and organizations are turning progressively toward care models that are emphasizing health promotion, disease prevention, various social and environmental factors have come to the forefront that are widely recognized as influential factors or determinants affecting patient health outcomes. And this has resulted in a shift away from putting the burden on the patient and focusing more on the environment surrounding them and their unique and individual circumstances. And so, in other words, these social determinants of health, things like transportation, education, income and employment status, housing, gender, race, ethnicity, etc., and the discrepancies that exist within each of these categories are increasingly considered to be distal causes or what explain these sort of adverse health outcomes within certain groups. But the question that I would like to pose here with you all today, and what we'll explore in the next few minutes, is what really is the origin of these discrepancies? And why are there such big gaps within groups that ultimately affect their health? Now, before we can get to answering that question, I want to first introduce and define the term structures, because as the title of this presentation suggests, we're going to be talking about structural inequity. And so before we do that, I want to make sure that we all have a good foundation, no pun intended there, before we dive a little bit deeper. So for the purposes of this discussion, we're going to define structures as the policies, economic systems, and other institutions, such as the judicial system, schools, etc., that have produced and maintained modern social inequities, as well as health disparities, often along the lines of social categories such as race, class, gender, sexuality, and ability. Now, when we think about those, it's a little hard to see how they can fit into this larger equation that we're looking at. So I want to try and relate this to something that maybe we are a little more familiar with. So anyone that has worked on a quality improvement project probably is already familiar with the 5 whys method. But for those who aren't, the 5 whys is a root cause analysis method that's used to essentially find the underlying cause or the root cause of a problem that we have, with hopes of taking care of that root cause so that we can fix the problem. Process is fairly simple. We just ask why until we get to the answer. And this is actually really how I like to look at the relationship between health outcomes and structures. So for instance, if we define our problem as something very broad, disparities in health outcomes, then we are looking at this, and in medicine and in healthcare especially, the first question really is why? Well, why are people sick? Why are people getting sick at different rates than others and having worse health outcomes than others? And we ask this in hopes of getting to the root cause. But because patients are different, because their needs are so unique, because their environments are all different from one another, we see that a lot of these different factors start to come up that really play into how, when, why they receive care, or even the quality of care that they receive. And those are what we refer to as the social determinants of health. Well, it's, again, this process is just to kind of like understand how we're actually getting to that root cause. And we see that social determinants of health are an important link in that chain for really understanding what the root cause is. And those root causes are what we are going to refer to as the structures. To illustrate this, I want to have us look at this map from the New York Times, which illustrates the risk for severe outcomes or severe illness due to COVID-19 infection. And the darker red that an area is shaded, that is the higher risk that's associated with being in that area. And this is by the county level. So we look at this and immediately we can see that there's a concentration of dark red in the southeastern region of the country. Well, my question is why? Why is it that area? So I'll have you look at this map, which shows the prevalence of diabetes on the county level from 2007. So we're taking a little step back in time here. And then again, the darker the shading, the higher the rate. So here we have the darkest red, which indicates that over 10.6% of the adult population has diabetes. And so you can tell pretty quickly here that a lot of that same region that's shaded darkest red here was also the same region that was associated with higher risk for severe illness due to COVID-19. And so maybe you're saying, okay, we already know about the correlation between comorbidities and susceptibility to poor outcomes with COVID, or maybe you're saying that, yes, this tells us a little bit about susceptibility. But again, what I really want to ask is why? Why is it this area in particular that has these higher rates of chronic illness, particularly diabetes? So now I'll have you look at this map, which shows persistent poverty at the county level from the 30-year period between 1970 and 2000. So again, taking an even further step back. And we're seeing that anything that's shaded a different color than gray or white indicates persistent poverty, but the lighter red shows non-metro areas, whereas the darker red or that maroon burgundy color is showing the metro areas or urban areas. And again, we can see really quickly that now we have overlap between all three of these maps that shows that, you know, it's not just a coincidence of, you know, comorbidities and COVID-19 outcomes that is just because of the prevalence of chronic illness, but we actually see that there could be a link here between poverty and these other illnesses and other outcomes we're seeing. And so again, we want to keep asking why. And if we keep asking why here, we essentially get to historical factors such as socio-political and even geographical factors that have really shaped the vulnerability of this area of the country. And so to look at another example related to COVID-19, and this I don't think is new to anyone, this pandemic has really revealed some very astounding disparities. But I think seeing it in a table like this, which is from the CDC, really just makes it painfully obvious. I mean, even if we're just looking at the case rate, we can see that anyone who is not white or non-Hispanic has automatically just a higher rate, 1, 2 to 3 times the rate of contracting COVID-19. And if we look at hospitalization rates, especially for American Indian or Native Alaskan Natives or Black patients, the rate is several times higher. And then if we look at the death rate for the Black population, it's more than twice as high as that of whites. And so again, we're wanting to ask why. And when we ask why here, we actually notice that the CDC has answered the first couple of whys for us at the bottom, essentially saying that basically not being white and non-Hispanic automatically puts you at risk for higher exposure to coronavirus. And that's due to things like socioeconomic status, access to healthcare, or just occupational exposures. But again, my question really is why? Why is that? Why does that racial divide exist? And so when we keep asking why, we get to some of the underlying causes, and one of the big ones being a very foundational component of our own healthcare system. We see that a lot of essential and low-wage jobs are filled by Black and brown workers, and it's the jobs themselves don't offer this type of employer-based health insurance. A lot of times, if the individual doesn't qualify for Medicaid, they aren't inclined to pay for their own plan or can't afford it. So that really affects how and when they seek care. We see that minorities already have a higher burden of chronic disease just because of existing health inequities. Redlining, that has resulted in a legacy of lack of generational wealth in Black and brown communities. So oftentimes we'll see folks living in multi-generational homes, and this creates higher risk for exposure when folks are going outside of the home and then coming back and they're having contact with multiple other people in the house. There's also gentrification, not a new thing. It's just been happening gradually over a period of time, but that has pushed these same communities out and away from areas that have higher concentrations of basic services like grocery stores and healthcare facilities, et cetera. And then not to mention racism. And unfortunately, this is not an exhaustive list, It's just some of the bigger factors that are affecting health outcomes, particularly during this pandemic. And it also highlights that a lot of these things are just very interwoven into our society, such that we may not really see them. But again, that's just coming back to the idea that social determinants can help point to some of those structures that are affecting health. And we actually like to refer to these as the structural determinants of the social determinants of health, just to kind of bring that point home that this is a process or a chain, and these are all different links within that chain. And so now, hopefully we have a little bit of a better understanding of structures. And so I want to have a poll question here and just ask you all, and you can type answers into the chat box, to identify one structure that you think affects the health of your patient population that you're serving if you are a patient-facing organization. And because there are so many of you here today, I think one will be enough, but we'll give you about a minute to go ahead and do that. So just type that into the chat box. Okay, income and education. I'm seeing poverty, housing, transportation, undocumented status, access to healthy foods, absence of insurance. Again, insurance goes back to the healthcare system and the need for that insurance, right? Immigration policy, yes, definitely. Availability of resources, food deserts. Oh, I see food apartheid. That's a new one. I've not heard that one, but I like it. Environmental racism, absolutely. Great. Yeah, I see a lot of really, really fantastic answers here. And I think we're all on the same page in terms of structures and how they can affect health and how prevalent they really are. So with that, we'll go ahead. And so now, having talked a little bit about structures and what they are, I want to bring it back to this idea that social determinants of health are indicators of structural inequity. So maybe you can see that sometimes the difference between structures and social determinants of health, or even just identifying structures themselves, isn't necessarily easy. They're hard to see. But rather you can see a lot of times the downstream effects, right? And we can measure those a lot easily. And in this case, the social determinants of health are actually the downstream effects. So when we are using enabling services to document SDOH and really collecting a lot of data on how those are affecting our communities, these can be really, really powerful clues for us about what structures are really at play. And because identifying structures can happen on an individual level, a community level, and because they're so varied and so many, they're not really a single formula or indicator to show exactly the structures that are having the biggest impact. So again, our SDOH are really the biggest link and most crucial link to understanding those greater structural level factors. And this has a lot of significance for health centers. Understanding the structural factors that affect health at a population level has huge implications for outcome-based payment models, as well as, in terms of thinking about resources that you'll need, whether they be human, material, financial. In this case, in the case of a pandemic, or in the case of policy change, how much outreach and enrollment will you need? It can help you create adaptable and specific services. But most of all, what this really helps to do is help health centers be better advocates for their patient populations by being proactive rather than reactive, because we know that health centers are such a vital component a vital resource for health in a lot of communities, that being able to advocate for them for their health equity and equality on a structural level can really ensure that a lot of your interventions and the improvement in outcomes is more permanent. And so just to kind of close out here, what we have been talking about here is often referred to as structural competency. And I know that sometimes it can be a little bit difficult and abstract to think about health and health outcomes on a level like this. And I think that's indicative of the fact that these types of conversations aren't really traditionally included in a lot of training and education for healthcare providers and those who work in the healthcare field. But at Health Outreach Partners, we actually offer a training curriculum that is of structural competency that really focuses on these upstream factors, how they affect health and healthcare delivery. We walk through case studies that are applicable to the health center setting. And we also talk about interventions to help sort of mitigate the negative impacts of these structural factors. And that can be for any group. We can customize it to your needs. If that's something you think that your team or your health center would be interested in, you can visit us at the website linked in here. I'll also put this in the chat box for anybody who wants to check it out. My contact information will be provided at the end of this presentation, so don't hesitate to reach out. And with that, I am going to hand it over to my colleague, Brett, who's going to help us put all of this together from a special and vulnerable populations perspective. Thank you, everyone.
Sorry, I'm unmuted now. Thanks, Bellany. I'm going to steal her disclaimer, and also for the sake of time, because we want to make sure we have a little bit of time at the end for questions or any kind of discussion. I'll kind of be going through some of my slides pretty quickly. Feel free to throw some questions in the Q&A or leave some comments in the chat if there's anything you want us to come back to. But like they said, my name is Brett Poe, and I'm a research associate at the National Healthcare for the Homeless Council. And I'll be taking us through our final objective today. In this last section, we'll take everything that we've heard so far and reiterate a lot of it, but with a lens specific to special populations, particularly people experiencing homelessness, and the additional barriers and risk factors that they face, as well as how to effectively navigate the tools and the resources that are available to successfully implement screening and addressing those social determinants of health. So just really quickly, I'll review again over this next section why SDOH is important to document for these groups, what to consider when choosing the appropriate screening tools, what resources are available to help screen and document in a culturally appropriate and trauma-informed way, and then review some best practices and notes from the field to address challenges that some sites have noted during implementation. And finally, I'll be sharing an upcoming opportunity that we'll have to present to dive deeper in potentially applying this implementation or program improvement at your own sites. So we know that screening for SDOH helps in identifying a patient's non-medical needs, and risk factors related to homelessness specifically tie across many of these domains and intersect with many of the factors that my colleagues and the others have already mentioned today. And primarily, we know that the lower the level of security across these domains, the higher the risk of negative health outcomes across a variety of chronic or overall health conditions. So the motivating question to screen for these determinants is, how can we assess these risk levels if we aren't collecting this non-medical data? And what are the best tools and resources to implement this? So here you have a crosswalk of SDOH variables. This is pretty similar to what Albert showed earlier. That are collected with the different tools. Several of these, again, have already been mentioned. And of course, as we saw in the polling, most of you are already familiar with Prepare. And the key thing to get from this slide is just to highlight the different variables along the left there that are collected by each tool and what to take into consideration when selecting the tools for your screening processes. So be thinking of what tools might be the best fit for implementation in your organization, thinking about what available resources you already have or could get access to, and of course your staff capacity to do that. You'll notice that Prepare has the most utility across those variables, and that but several of those are optional and can be determined from site to site based on many of those factors. So we'll be talking more in just a little bit about what some sites might be doing in those instances that staff capacity or resources are low, and how that might determine if you choose to incorporate certain data collection in your screening processes. And just a real quick breakdown of some data that I got this morning of the use of a couple of these more commonly used tools. This is from the 2019 UDS, and this is broken out by the programs, about 300 programs that receive HCH, Healthcare for the Homeless funding. So of those 300 HCH sites, 231 do currently screen for social risk factors, so about 77%. And Prepare is the highest used tool among them. 89 said that they do use Prepare. A handful also use the Accountable Health Communities tool. The second highest reported of that was that they do not use a standard screening tool, but they did indicate that they may have other domains that are included in their EHR systems. So similar to one of Esley's previous slides, in thinking through the implementation of the screening process, we have talked about the what and the why. So now we'll talk about the who and the how and at what time. So be thinking about what stage of the visit might make the most sense to do this type of screening. And as Albert mentioned, this can vary. At some sites, screening forms might be completed at intake along with some of the other record keeping. Other sites have specially trained staff like nurses or case managers that then meet with the patients and talk through the questionnaires in a private room while waiting for the visit with the primary provider. And then others have chosen to follow up after the visit so the patient doesn't feel like they're being delayed in getting to their primary appointment. So these are all things to take into consideration, including the relationship between the patients and the staff and what's most culturally appropriate for them. And this may differ from site to site based on your staffing. So do you have community health workers or peer workers that patients might be a little bit more comfortable with answering some of these types of questions, taking into account the provider and the patient relationships and potential differences in those relationships with the primary providers versus medical assistants or nurses, and considering those power balances between who's asking the questions and the comfort level of the patients in responding to those. And so it's come up a few times, and I've mentioned a couple of times that training may be required for the staff that are going to be asking these questions that address SDOH domains. And how to ask the questions related to housing instability may be sensitive, and people may not readily self-identify as homeless. And the Prepare tool and some of the others do frame some of those questions in a decent way. You know, what is your housing situation as of today? Answers being, yes, I have housing, no, I don't have housing, with various descriptions of scenarios that can then hone in on determining the sheltered or unsheltered status of that individual. And also that ask about their housing stability. In the Prepare, it's, are you worried about losing housing? But some other approaches may be more conversational, a little bit less prescriptive. It might be more comfortable for patients to answer, such as, where did you sleep last night? Or are you concerned about where you might be staying next week or next month? And those kind of conversational discussions can help get to the answers that you're looking for without maybe being so direct or seeming so intrusive. And another thing to note here is that coding for special populations, particularly as it relates to homelessness, are often not correctly reported or underreported. And there's a great resource here, linked at the bottom of the slide, on how to ask these types of questions and how to properly code housing status using Z codes. That can be useful when considering value-based reimbursements, important information for payers, public health goals, and policy initiatives. And so what are we asking? The resource that was linked on the previous slide, and I'll post it in the chat here in just a second, is then Ask and Code Policy Brief. It addresses many of these types of common questions and offers strategies to incorporate these into existing processes and electronic health records or data systems that are already in use for easier reporting. And we know that this is a limitation for many health centers, but those that are able to integrate SDOH fields into their EHRs, as opposed to free text fields, can generate reports specific to these risk factors and even incorporate automatic prompts to follow up with the patients at certain intervals during their regular visits. based on their responses to these evaluations for reassessment or to reprioritize their personalized care. And so then how are we coding? So specifically coding the documentation of homelessness. For those that may not already be familiar, this slide just offers a quick definition of the ICD-10 Z code series as they relate to SDOH documentation related to housing, with the Z59 codes being specific to health issues related specifically to housing and economic circumstances. So people experiencing homelessness, as I said, are often underrepresented because of inconsistent or underreported data. So it's important to define this as accurately and consistently as possible. And I'm going to link this to everyone right now in the chat. Great. So then some additional training materials for staff that are asking these questions related to SDOH. Here's a source, a resource for practices that was published by the HCH Clinicians Network. And this is a Healing Hands issue that highlights the importance of developing an environment of trauma-informed care and how to practice motivational interviewing as a trauma-informed treatment approach. And being comfortable with these types of interactions are beneficial for those on the workforce that are tackling these areas of questioning and for the patients being presented with these questions in an approachable way. And then taking a step even broader from that, this is a link to a recently developed trauma-informed organizational toolkit. This was developed by the council from one of the last cycle's 3-year learning collaboratives and a best practice report. It includes many comprehensive links to break down various ways to approach organizational assessment, organizational readiness, change development, and implementation to become trauma-informed. So I'll link to that toolkit here as well. And these last couple of resources are really just meant to ensure that the appropriate staff and organization as a whole is equipped with the right background and common language tools to approach asking and addressing these SDOH domains in a culturally sensitive and appropriate way. And I think I might have accidentally just posted all of those links to the panelists. So if one of my fellow panelists could just copy those into the chat for everyone, that would be great. So I would like to pause here just for about a minute to ask the group, what do you do in your current practices if you can't address someone's needs that may be uncovered by asking questions in the SDOH screening tool? So Albert, if you could post that poll. Perfect. And so you'll see some options here related to referrals to partnerships, if those are already established, following up with future resources if you don't have those already established, documenting those areas where the resources are lacking, or maybe not even asking the question at all if there aren't existing resources that are appropriate to address that need. So we'll wait until we just have a few more percentages to vote. And I have heard several discussions in the past with different schools of thought on the value of going ahead and getting that data for future follow-up versus the potential to damage the trust with patients if you don't already have that immediate response for their needs. So I'm curious to get a sense of what this might look like with the group. Okay, yeah, so it looks like most is to refer to existing partners or get contact information to follow up. Great, yeah, I think we'll go ahead and end the poll there now. That's about what I was expecting, but I have heard some schools of thought to not ask if you don't have that available. So that's interesting. And we can use that as sort of a launching point if we have some time here in a little bit to use in our discussion. All right, so thinking about implementation again, The next few slides might help provide just some insight on how others have addressed that question. These summarize a prepared brief with lessons learned and considerations from a previous learning collaborative and a series of listening sessions and a focus group that was led by the Council and the Corporation for Supportive Housing. And these are just meant to highlight some of the best practices and how to go about establishing partnerships or infrastructure if the capacity within your organization doesn't currently exist. And so I won't read through all of these tables, but I'll just pull out some of the key points of what participants in these sessions said were the key successes to addressing these challenges. So for lack of training, detailing of the tools and access to the skills development that are available in areas like trauma-informed care and motivational interviewing was a successful approach. Acknowledging the burden of data collection, and it was considered successful to have the tools for SDOH be more distinct from those that are used for medical history, and that conversational approaches with the patient was more successful than paper documentation, for the most part, at least as identified by these groups. And then also just the availability of multiple tools. So there being more of a concentrated effort of making sure you are choosing the right tool to screen and increasing access to trainings on those tools. And then again, for data storage, just acknowledging that it works best if then what you've collected is incorporated into an EHR to have that provider prompting and integration into care. But again, acknowledging that there is significant effort associated with being able to do that. And knowing where to refer and how to follow up. So authorizing enabling services workforce and staff to develop a resource guide that then everybody else can use to follow up with patients following these assessments. And then the importance of using the data to see and understand the impact on the individual level, as Lee was saying, for these person-centered approaches to these care plans. And to address lack of capacity, the best practice was to identify partnerships and utilize established referral practices. And I know that sounds sort of vague. So I wanted to just provide a really quick example of one that I know of. Compass Healthcare in Ohio, when they were going through a few years ago to implement their screening process, they did a community survey of resources and community service centers that were just in their area and their neighborhoods while developing their implementation plan. And this way, even if they didn't have a formal partnership or a referral process yet, they created sort of a one-pager or a brochure of available resources to provide to patients following the screening. And this allowed the patients to then have some sort of way to follow up, and then staff would note if there were areas that were answered in the screenings where services still may not have been available, and use that as a way to identify the need for potential new programs or partnerships that were needed. And finally, it was noted that utilizing this data is beneficial to accessing potential funding opportunities to fill those gaps where resources are needed. And as we talked about and Albert had mentioned kind of earlier, enabling services data collection is not very comprehensive in the uniform data system, which are often used for benchmarking purposes. So some enabling service providers are specifically identified, but not all of them, and others that may fall under enabling services aren't explicitly prompted and may be written in. And the way that these are written in aren't always consistently named or titled the same across organizations, or they may be combinations of many of those types of roles. And these definitely don't include all of the categories presented as part of the 15 extended services that are listed in the enabling services data collection toolkit. So again, increased data increases the demonstration of impact and the need to create partnership proposals or other resources, which ties us back to the importance and the utility of that standardized toolkit that Albert had presented earlier. And then this brings us to a final tool that can be used to address these topics in a deeper dive that can be applied to your individual sites and wherever you are in the process of implementing SDOH screening. This is an upcoming learning collaborative that starts next Wednesday, and applications for this are still open through today. We'll be following the model of walking through a change map to identify and address areas to improve implementation. And I'll just quickly walk through this because this is a tool that can be used outside of a learning collaborative. We'll just be providing that space for it. But what that process looks like and how the tool can be utilized as a way to self-implement and evaluate really any initiative or activity. So this model will break down all these questions that we've been asking throughout today's webinar in a really site-specific way. And it's sort of like a reverse engineered program evaluation tool. It was developed by Warren Berner here at the council to start the process of program planning. So a lot of these questions we've discussed over the course of today's webinar are seen broken down into key areas to consider the steps to success. So looking at the background of the problem, the action plan, the support that would be needed, implementation details, and how progress will be monitored. I mean, this tool is also useful to demonstrate that these considerations have been thought through to gain buy-in, as Leslie was saying earlier, to get that buy-in from either your leadership or if it's coming from leadership, get buy-in from the staff who would then be implementing this new program. So just depending on who's initiating that process, it's good to see that these things have been considered. And then those key areas correlate to a visual roadmap originating from that identified problem or need and takes you question by question towards that established goal. And the responses to those questions become your actionable steps toward implementation. And just to show an example of what this looks like, it looks kind of busy, but this is from a previous learning collaborative that was addressing possible interventions in diabetes control from a health center site. And this just shows the final product that was used as a proposed implementation plan. I mean, the sites that participate in the learning collaborative and that do create these change maps receive a certificate of completion, as well as this final document then to share with their teams. And so the upcoming series will break these steps down over the 4 sessions with updates from the participants that will guide the conversation and what key areas they need to be focusing on and which steps they need to build capacity and their utilization of these SDOH data. And by this point, participants really, by answering these questions, have effectively drafted all of the key components that are seen in most funding proposals or grants. And the existing work then that you've just done can be applied with the aim to implement at your own sites. So not everyone has to take these steps to that level of writing a proposal or submitting for a grant, but we found that it has been helpful for participants to utilize the learning collaborative opportunity with that kind of end goal in mind, and then they have something tangible that can be utilized if there does become an opportunity for that. And so with that, I know we are running very short on time, but I'll open it back up to the group and see if there's any way we can address any of these questions or to my co-presenters to respond to any questions you may have.
Thanks, Brett. Yeah, we have a few minutes left, so if any of you who are still with us, please chime in with your questions using the Q&A pod. I think I see a raised hand from Johnny. So I'm going to allow you to talk, Johnny, in case you want to speak up verbally. So, all right. Johnny, you should be able to unmute yourself and ask a question.
That was actually a mistake, but I would like to say it was a lot of information in a short time, and it most of the stuff you said correlates with what we're doing in our FQHC. Very good information shared. Thank you, guys.
Thanks for joining us, Johnny. I appreciate it. All right, Elisa, you are going to be allowed to talk and unmute yourself, so feel free to.
Hi, thank you. This was very good, and I'm the CEO. I'm a pediatrician, and I wish some of my other staff was on it. Are you saying there's a learning collaborative and the application is due tonight?
Yes. So that application is available.
What?
The link is available in the chat box, but we can follow up with you. We encourage you to, pass it forward to your staff if they're open.
But it's due today. Is it a complicated application?
Not really, Brett. We estimate like 10 minutes of your time.
And what's the time commitment for our staff?
So the Learning Collaborative series is going to take place over, I believe, it's between 6 to 8 weeks, but it's 4 sessions across those 6 to 8 weeks. Mm-hmm. And the Learning Collaborative sessions are 90 minutes each. Mm-hmm. They do include some of the homework of just in between those sessions, going through some of those questions that are asked to kind of guide the conversation for the next session.
Okay. I think one of the challenges, I've been talking about social determinants of health for my entire career, which is quite long, is that there are so many different places that the questions exist. And we did a crosswalk a couple of years ago, and it's very challenging because you have to ask it in so many different, there's so many different places that you're required to be screening people now for the same questions. Could you comment on that? And then I think the other is, where do you capture the data packet? Oh.
Yeah, I mean, I'll defer some to Albert on this. I mean, I know that we definitely acknowledge the burden of over surveying, the survey fatigue, and asking too many of the same questions in too many different places, and patients just don't want to respond to that many times.
Mm-hmm.
I think that was sort of one of the intents of trying to push the enabling services data collection tool,
Mm-hmm.
not to compete with the questions that are asked and prepare, but maybe as a way for the health centers to document how they're addressing those determinants.
Mm-hmm.
But I'll kind of give that over to you, Albert.
Sure. Yeah, one of the things for the Health Center program is the prepare questions, which are 21 questions total. 9 of them are UDS already questions. So we encourage a crosswalk with what's already collected in the EHR, EMR. And so that leaves the Health Center staff who are collecting and screening to just really document the other core questions, especially around transportation, housing, insurance, employment, et cetera, et cetera. And so the questions that are left in the prepared questionnaire have not been too heavy of a lift from the health centers that we've been talking to. It's more of just first doing a crosswalk on what's in the EMR, and then doing on a workflow perspective on the back end, mapping that data into a report. So if you have an informaticist or a population health management team that can really manage all that data on the back end to give a meaningful report to clinicians or staff that are going to be addressing the SDOH after the patient's visit, that will help a lot.
Okay, thank you. And you guys will be teaching those webinars?
Yes.
This was very good. This was very good. So I'll see what I can do. Thank you so much.
And yeah, we'll keep it open. Probably someone asked if we can extend it. Brett and the team, I'm sure we can open it up for another, what is it? Today's Wednesday.
Yeah, I think we could leave that application open.
I think it's a very hard time. I mean, it's, we are all very distracted, and, things happen constantly right now. So if you can leave it open, I would appreciate it. Then I can really try to circle back with my staff on it. But let me know. Or I can have my staff check.
Sure, yeah. I think we can definitely leave it open for at least a couple more days.
Okay, thank you so much. Appreciate it.
Thank you.
And this recording will be available soon or not?
You will get the recording and slides in a follow-up email within 48 hours. So check your inbox.
I'd like them to see this before we do the application. I think that would be helpful. But okay, then I can at least give them the slides and have those. Thank you so much.
Thank you, Lisa. All right, lots of great questions. So, I mean, I can stay on for like another 10 minutes. So we can finish this up. Brett, Esley, Bellamy, if you're okay with that.
Sure.
Let's see what else is coming through the inbox. Oh, someone asked about the Learning Collaborative again. Do you have to attend all 4 sessions? Yes, that is definitely required for the health centers who are participating. In that sense, if you have another colleague who you can do the Learning Collaborative with within your organization, that'll help kind of translate information across your health centers. So you don't have to apply as a single person, you can apply as a team. So I think I'd like to encourage at least 2 people. That way there's divvied up roles and responsibilities and information that you can share back. So anything to add, Brett, Bellamy, Esley?
Yeah, I mean, and we also do we record the sessions, and we do create a platform for people to access materials. We would definitely encourage, to get the certificates of completion, you need to attend all 4 sessions. But yeah, we would definitely encourage you to attend all, but we understand that obviously things come up. But yeah, like Albert said, if you have secondary or even third team members that are interested that can join instead, that's definitely encouraged and welcome.
Right. I put the link in the chat box again. So Anita asked if, so PCAs and HCCNs, you are able to apply. So please do, because we understand that there is information that you can disseminate to your health centers who are not a part of the Learning Collaborative. So yes, please do apply as a PCA or HCCN.
I see a question on if the Learning Collaborative is for teams that are new to SDOH or already implemented. And I think one of our goals is to have a wide array of levels, right? Because it's a learning collaborative. So the point is that we learn from each other. So it's open, whether you're just starting or you're seasoned, I'm pretty sure we can learn all together.
Absolutely.
Yep. And since you'll have 4 of us kind of helping with the facilitation and coaching, we're going to divide ourselves up into cohorts. So we can easily go into kind of beginner, intermediate, advanced levels. That way we're meeting everyone's needs in the Learning Collaborative. So we will do our best to address everyone's kind of capacity and their knowledge levels. All right. Question from... And so Brittany, sorry, yes, you will get an email within the next 48 hours with all the resources from today's webinar, including the recording and slides. So please share amongst your staff. Sheila, the enabling services documentation template examples. Are there? Yes, so that is available in some EHRs, the main ones including NextGen, ECW, GE Centricity, which I believe is now called Athena something, and then Epic. So there's an integration between the enabling services and the prepare questions happening right now. So AAPCHO and NAC are working with some of the big vendors that health centers are using to integrate the prepare questionnaire to the enabling services categories. So there's a lot happening in the vendor space, and I look forward to sharing that in future trainings as we release those for pilots or for utilization in your EMR EHRs. All right. Okay. Anything else that comes out to you or points out to you, Esley, Brett, Bellany?
Just a question from Elisa. I don't think you addressed it. If they participated in a past Prepare Learning Collaborative, can they participate in this one? The answer would be yes. And then how would it be different? The main, I'm not familiar with whatever the previous Learning Collaborative focused on, but the way this one would be different, from my experience, would just be this one is very self-driven, very much facilitated and less in tutorial, or it's not going to be a webinar type of format. It's going to be some framing, conversation, and then led by the participants of the Learning Collaborative kind of through that change map process. So from my understanding of some of the other Learning Collaborative approaches, that's how this one would be different.
Yeah, and just to quickly add, there are separate Prepare specific trainings that are going to be offered by the Prepare team. So if you're not a part of that listserv, I encourage you to, let me put the link in here, but that'll give you the updates, because this Learning Collaborative is going to talk about Prepare as an example, but not necessarily just talk about one screening tool, since we want to be inclusive of others that are using, again, the Health Leads tool, the CMS tool. We want to make sure that we're acknowledging all our other partners in this work. All right. So I know I have to run to a meeting. So if you have any more questions, please reach out to us four. You will have all of our contact information here on one of these last slides. So thank you so much for joining us, and we look forward to more applications for the Learning Collaborative. That'll definitely be a deeper dive on today's session. All right. Thank you all.
Thanks, everybody.
Thank
Thanks,
you.
everyone.